and attend in person. And obviously, with that, I will ask Al to join me here and give a brief introduction to Rohan. Welcome, Rohan, for joining us.
So my pleasure to introduce Rohan Dharmakuman, who is the current executive director at the Krannert Cardiovascular Research Center and the Charles Fish Professor of Cardiology and the Director of Cardiovascular Imaging Research there, as well as the Research Director at the Institute. He got his undergraduate degree in physiology and physics, a master's degree in science and mathematics, and a PhD in medical physics, all at the University of Toronto, and then did postdoctoral training in MRI, both at the University of Toronto and at Northwestern, and then joined the faculty at Northwestern for a period of time, and then moved to Cedars, where he stayed for many years and sort of went up through the ranks, became the director of translational cardiac imaging there, co-director of PET-MR research, and a professor at Cedars, as well as a professor at UCLA, and then was recruited in 2021 to be the executive director at the Krannert Cardiovascular Research Center. And he has many active R01 grants, has been funded for many years evaluating ischemic injury, applying advanced cardiac MR technology and development of advanced cardiac MR technology. He holds many patents that have been issued and pending in this space, and has well over 100 publications related and focused on the application of advanced cardiac MR in the evaluation of ischemic injury, and is going to talk about some novel concepts with regard to myocardial hemorrhage. So let's welcome Rohan.
Thank you, Eric. Thank you, Al. Thank you for the invitation. Real pleasure to be here. Had a really great day speaking with everybody. Fantastic place you have here. Just as I was telling Al, it's nothing like I've seen before in the sense of all the different imaging modalities and tremendous support of the institution. So just really amazed. So today let me see if I can get my slides here. Yeah. Hopefully the MR folks don't get disappointed. I'm not going to talk about really hardcore MR technology, but I really want it to be a talk on intramyocardial hemorrhage in the setting of reperfused MI, which is what we do, right? So this question of does it matter is not really something that I put on, but it was a question that was posed to me about 20 years ago by the Feinberg director of Feinberg Institute of Cardiology director. He said, well, yeah, you can see this with MRI. So what? What's the big deal? And we know about this, and we've known about this for 20 plus years anyway, so it doesn't really seem to matter. So somewhat unplanned, but this is the way my life has been evolved, really been trying to study what intramyocardial hemorrhage is and what it does in the heart. And I hope to be able to, capture this sort of, growing pieces of information that I've pieced together with many of my colleagues around the country and outside the country on reperfused myocardial infarction and the involvement of intramyocardial hemorrhage, both in terms of a pathophysiology standpoint, but also from clinical outcomes. These are my disclosures. No need to tell you what myocardial infarction is, but it happens in an alarming rate. It affects so many people every year, and it is a big cause of death and morbidity in the country. Not only here, but also if you look at what's happening in China and India, we are into multiple millions of patients having myocardial infarction, and really the prognosis on many of those patients are particularly bad in the STEMI population. So guideline-directed therapy for myocardial infarction, of course, is the mechanical revascularization through percutaneous coronary intervention. So, typically you revascularize and you get a TIMI-3 score and everything is good, or it seems that way at the turn of this, around in the late 80s when it started. But as we've kind of gone on and learned more about it, and it doesn't look like everything is great with revascularization, although it has been life-saving technology. So let's take a close look at this. This is the impact of reperfusion therapy on the final MI size. So this is some of the pictures I'm taking out are from Yellen et al. From New England Journal of Medicine that as they presented this, but I'm capturing this and kind of presenting it in a way so you can understand where I'm going with this in time. So in the absence of reperfusion, we understand that the entire area at risk can completely become infarcted and become essentially necrotic and then essentially fibrotic. So the benefits of reperfusion are really real. So the desired effect of reperfusion is that the white areas are, by the way, the infarct zones, and that's what we want. We want to be able to match the ischemic time that's gone on, and that's nothing you can really do about it, and then have an infarct size that is proportional to that. But that's not what ends up happening, and because in many of the cases, what we end up getting is larger infarct size, right? And what we want to obviously avoid is having a therapy that ends up giving this type of results. The benefits of reperfusion is nearly entirely abolished, yet we don't even know about it, right? And that can happen within about 24 to 48 hours. And that is what I'm going to be talking about. And you'll see that how all of this comes together as we get closer to the end. So benefits of reperfusion therapy on MI size is variable, and I think that's fairly well documented. So the question is, why is that? So, and if you look at the literature, going back to the 1970s, Robert Kloner's work very nicely demonstrated that when you reperfuse and you open up the epicardial coronary artery, that you can have pretty good flow in the epicardial coronary artery, but the downstream smaller microvessels can remain plugged, and he demonstrated that in a very celebrated paper of no reflow phenomenon, and now it's really called microvascular obstruction very commonly. And this is ex vivo data, but now we can actually see this with MRI. So that is really a big evolution in imaging technology that allows us to see that. And so this is data from the 70s, but it is a real problem, and it is really probably the first demonstration of reperfusion injury in a serious way. So in microvascular obstruction, what happens is that the microvessels are plugged for a number of reasons, but really diminishing flow and exacerbating this ischemia to persist for a longer period of time than actually intended with the epicardial reperfusion. Now, associated with this vascular injury, reperfusion injury, is this concept of moving from microvascular obstruction to microvascular destruction. So this is where you revascularize and you have the microvessels just bursting out. Now, when they burst out, what happens is that the red blood cells come into the interstitium, and that sets up a whole different pathway. So one of the things it does is that it makes the microvascular obstruction that much worse. So microvascular obstruction, there's greater microvascular obstruction that happens with intramyocardial hemorrhage. That's the first thing. And so the ischemic damage actually becomes larger. You can imagine that because of the ischemia. But what else happens is that when the microvasculature breaks and the red blood cells are out in the interstitium, the red blood cells themselves start to break down. The problem is when that starts to break down, hemoglobin starts to break down. Hemoglobin is a great thing for human body, but when it's in the intravascular interstitial space, it's terrible because first thing it breaks down into is heme. And heme is cytotoxic, and heme is actually shuttled very quickly into the mitochondrial bed and really starts to cause all sorts of havoc and starts to induce a process called ferroptosis, and that drives a whole lot of cell death. And we'll see a lot of that in a bit. But essentially, this is microvascular destruction. Microvascular obstruction is always there, but microvascular destruction happens, and then you have all this bleeding happening in the heart. And this was described by Michael Fishbane also in the early 80s. Now the question is, And again, this is all histological studies, right? So the power of imaging is really impressive when you look at the literature and connect it to what's happening now. And it's really what imaging has allowed us to do is to really understand the pathophysiology over a period of time. And we can actually study this evolution of injury, not only in the acute phase, but in the chronic phase in these patients with hemorrhagic infarcts, and then look at outcomes without having to do histology, because histology is a single time point event. And so this is Yellen's paper, and they've described this in a review paper in England Journal of Medicine in 2007, where they really disclosed the idea of reperfusion can actually lead to reperfusion injury. And what the whole goal is to do with cardioprotective therapies, which I don't think have really come out in a significant way to benefit patients, is to salvage the myocardium better than if reperfusion therapy were to be taking place. Reperfusion injury were to be taking place after reperfusion therapy. So here's the problem. The biggest problem is that once the cardiomyocyte necrosis starts, you have an enzyme release, then you have a detectable necrosis, and you have fibrosis that happens, and then you have two different clinical outcomes. One is heart failure or sudden cardiac death, and could be due to arrhythmias and things like that. So the prevailing understanding is that the scar size is predictive of outcomes. A number of studies have shown that. Nobody's going to argue with that. Well, what has also happened in the past, I don't know, 10 years or so, with the advances imaging has made, particularly MRI, is that we have come to understand something else. And that is actually a little bit more scarier than even infarct size. And that is, if you have microvascular damage post-reperfusion, you carry a fourfold greater risk for major adverse cardiovascular events than just the scar size alone. So what's going on here? What is that is something fundamentally different than just looking at scar size. So scar size does contribute, no question about that. But you have people who have compromised microvascular beds that are at even greater risk. So this is kind of along the theme that I'm talking about, right? Then you look at this outcomes data that's coming out incrementally in the literature. These are MRI studies where patients have been followed for a number of days post-reperfusion. And if you start to characterize these patients on the basis of tissue injury that's taking place in these patients, and you pull them into patients that don't have any hemorrhage, don't have any microvascular obstruction, and then you pull them into those with microvascular obstruction but no hemorrhage, and then you pull them into microvascular obstruction and hemorrhage, the outcomes look very different. The cases that have hemorrhage have had very bad outcomes. And that is one study that came out in 2011. And for MR people, they were using T2-based approach for identifying hemorrhage, which has a loss of sensitivity. So that, I've been longing for somebody who would publish a paper with T2 star in clinical outcomes. And that came out from Ingo Eidel's group in Germany just a few years ago. And that also very nicely showed that indeed, if you have intramyocardial hemorrhage post-revascularization, your outcomes are really much worse. Okay. So the first question, I'm going to present these questions because these are the questions that I've been asking and trying to resolve them in the way I've done them, and not probably the way I would write them now, because we know a lot more than we did. So this is work that we started at Northwestern, also on a cloudy day like this, but I still remember some of these studies, and they were all done in dogs. And what we did here is that we induced ischemia for 3 hours in an open chest model. We're doing all of this, by the way, inside the magnet. Okay, so we created the ischemia, and then we reperfused, and we would image pre-reperfusion, post-reperfusion, and then we would bring the animals and scan them every 2 days for about a week, and then we would scan them 8 weeks after. So the conventional wisdom at that time is that, okay, hemorrhage happens. If it happens, it's gone by, I don't know, a week or 2 weeks or something like that. Everything's resolved. In fact, papers have been written on. So we look at this in chronic infarction, and most people would know what late gadolinium enhancement is, since the standard technique for looking at fibrotic tissue, is a remarkable evidence in what MRI can actually show in terms of infarct damage and fibrotic tissue and the gold standard histology, which is TTC. You look at this and go, wow, this is amazing. But there's a lot of issues behind this, and that we cannot actually capture with MRI. So here's a study that we did, and this is data that we published almost 10 plus years ago now. This is an animal model where we've actually caused an infarction, ischemia, reperfusion injury, 3 hours of ischemia, post, and then reperfusion. LGE performed on, I think this one is a day 3. And that is telling you very nicely a couple of things. One, there's definite infarction in the anterior wall. And you have a massive microvascular obstruction, which is indicated by this dark zone within inside that bright ring. And so there's a significant microvascular obstruction. Fine. So before we did that, we do what's called T2 star imaging. T2 star imaging would identify hemorrhagic infarction. And when we did that, we can see this very black signal there, hypointense signal. And that is intramyocardial hemorrhage. So when you look at the LGE and you look at it in chronic phase, it's typically around 8 weeks in dog models. You look at this, well, everything is gone, right? I mean, it looks like it's infarcted, it's turned into fibrotic tissue, it's very homogeneous. But then if you did the T2 star MRI, it's a totally different story. See, what happens is that we see this sort of dark zone here. We didn't know. We thought we were looking at an artifact, honestly. And we said, okay, we got to do this again because we can't come out into the literature and say that there's something going on and there's hemorrhagic remnants that are still there, because that's not the conventional wisdom at that time. So we did this over and over and over. And then we did histology. Sure enough, hemorrhagic remnants do not leave the heart. They stay. So the next questions that we would ask would be more pathophysiological in terms of trying to understand what is and why is this happening? What's going on? Does this even matter, right? So when we went through this and we started to study this very closely, we did a lot of TTC stains and H&E stains and Mason's trichrome stains. So H&E gives you general damage. Mason's trichrome is going to tell you about fibrotic nature of that tissue you're looking at, and then pearl stain or Prussian blue we used to look at the presence of iron. And clearly enough, on the images that you're seeing here, these are again dog tissues, and where you had hemorrhagic infarct, these are explanted hearts 8 weeks after, you can see a very, very big difference between infarcts that had hemorrhage in the acute phase and infarcts that didn't have hemorrhage in the acute phase, and how they would actually evolve in the chronic phase, noting that there's no major differences in the remote myocardium. So we are very clear that there is iron deposits that are in the heart at least up to 8 weeks at this point in time. And then we looked at even other markers that are pro-inflammatory markers. And we looked at cytokines, CD1, IL-1 beta, TNF-alpha, MMP9. And what we were finding with the quantitative histology that we were doing is that there's a correlation between the amount of iron and spatially localized pro-inflammatory burden coming from cytokines. And so clearly there's prolonged activity, prolonged inflammatory activity that is taking place in the presence of iron that we are not seeing in non-hemorrhagic infarcts within the chronic infarct. So there's fundamentally something different about hemorrhagic infarcts in the chronic phase than in non-hemorrhagic infarcts in the chronic phase. So we went deeper. We started to delve into scales that are even tighter scales. And this is help we got from the Pacific Northwest National Laboratory. It's a federal lab where we were able to study this even much more closely. And what we did, we started to look at where these ions are coming from. So the ions seem to be inside macrophages. And as we looked closer and closer, I don't know how much data I can present here, but what we were seeing is that they were actually being posed inside lysosomes, and the lysosomes were rupturing. And it seemed like when the lysosomes ruptures, it sets up an inflammasome activity to take place. And so one of the things that we demonstrated is that when you have iron getting into the lysosomes, there is some sort of a biological process that's taking place that is turning that accumulation of iron into a crystalline state. That is important because if you know about gout, it also works very much with the silicate crystals, and this is the same process of a prolonged inflammatory burden, and that drives the process. So, and we found a lot of insight in you know, by looking at this from the perspective of a crystalline state, crystal-mediated inflammatory storm, cytokine storm. And then we did diffraction spectroscopy further, and we characterized these rings, which allowed us to look at the chemical composition of the iron oxide that's being formed. And then what we were doing, I don't have the data here, but what we would do is we would fabricate those iron particles and feed them into cardiomyocytes in culture, actually not cardiomyocyte, macrophages in culture, and we were able to see them spewing out, you know, having elevated gene expression of those pro-inflammatory cytokines I showed you, and also protein expression. So chronic iron deposition that happens in the heart is pro-inflammatory, and it's inflammatory, and it lasts for a long period of time. So if you've heard infarcts that don't heal for a longer period of time, hemorrhagic infarcts at the index site of injury may be what is actually driving it. So iron that's inside these infarcted regions are crystalline, and they're trivalent. And that's important too. And it's intracellular. Most of them are intracellular. Okay. Excuse me. I'm going to... Okay. All right, so we proposed a crystal hypothesis, essentially that the monocytes that are recruited are scavenging these ions, and the iron accumulates within lysosomes and causes crystals to damage the lysosomes, rip them in, activates the inflammasome, and cytokine is actually released. And then these then participate in infarct remodeling. This is work, quite a bit of it that we've done, but there's still work that's ongoing. And this is with respect to hemorrhagic infarction. Now you might ask, okay, this is all great. This is all in dogs and you can do all these things, but is it real in patients? And so one of the things that we published in 2013 is we showed that these iron deposits are out there in patients that are revascularized for STEMIs up to 6 months. Now, we showed that up to 6 months, but others now have just very recently, within the past 2 years, less than 2 years, from Germany have demonstrated. I mean, many people have reproduced what we've actually published in Circulation in 2013. But this is an interesting paper because this is showing chronic iron deposits in the heart lasting for about 10 years. At least that's how far they went. So this doesn't seem to go away. This seems to hang on. And you will understand why this would be important as I move through with other animal studies to try and explain why these hearts remodel so badly. So this is work we did, and we just published this also less than a year and a half ago in Nature Communications, where we demonstrate that hemorrhagic infarcts actually go through a transformation that is not seen in non-hemorrhagic infarcts. That is, these infarcted tissue with hemorrhagic infarcts actually become fatty. So the infarcts that become fatty are the ones that seem to be in the chronic, seem to be emanating from the point of hemorrhage. Okay, so this was a multi-institutional study. Many people were involved. Many people contributed an enormous amount of support from NIH. And we did this study. It took almost 8 years to finish, but it was a very complicated study using a number of large animal models where we demonstrated the following things. So we demonstrated a mechanistic pathway. I'm not going to go into that, but really fatty replacement of fibrotic tissue becomes time dependent and depends on whether they had actual hemorrhage or not. And this is tissue collected and analyzed histologically in an 8-week-old MI. Now, if you look at these dogs at 6 months post reperfusion, it's actually quite remarkable. You get something like this. It's massive amount of fat infiltration into the zone. What we are seeing essentially is iron getting involved with the macrophages and turning them into foam cells. and it's the foam cells that are being deposited. A very similar pathway, by the way, happens with atherosclerosis too. So it's not surprising that we're seeing this, but the amount of fat that we are seeing is really, really incredible histologically. So we did an MR study, right? So we are doing an MRI study. So we're looking at hemorrhagic infarcts and non-hemorrhagic infarcts, and we would do the serial imaging over a period of time. So we would do it at 8 weeks, and we would do it at 6 months. Actually, we went out up to a year and a half. And this is what we found. So initially, in hemorrhagic infarcts and non-hemorrhagic infarcts, there's no relationship between 1 over T2 star, which is a proportion of the concentration of iron, and the amount of fat that is in there. And you can measure iron, fat, everything with MRI. Not easy, but it can be done, and we were able to do it. We're a very strong MRI group, and we've also had support of others that were studying iron-fat separation, particularly Scott Reeder and Diego Hernando from Wisconsin. Anyway, so we don't see anything in the acute phase, right? There's no correlation whatsoever. But watch what happens as the time steps up. So as you go from the green curve to the blue curve to the red curve, that's all shift in time. As the time moves up, the amount of iron actually correlates with the amount of fat. But you notice that this correlation does not happen in non-hemorrhagic infarcts. Again, this is an associative study, right? It's demonstrating that there is a relationship between them. I've also demonstrated histologically that there is something happening with respect to iron and fat. So we went deeper. We looked at electron microscopy, and we were looking at fat infiltration and iron, and we were able to demonstrate that these fat globules and spheroids that were there really also had lots of iron. So this is sort of a generalized pathway. There's more details in the paper for those interested. So iron actually recruits the macrophages and goes through this foam cell and spheroid formation and foam cells, and they undergo apoptosis, and this basically triggers this growing fat depot. But one of the important things that happens is that this inflammatory cascade that takes place is that when iron is actually internalized by macrophages, unpolarized macrophages, they seem to also help with the differentiation of the macrophages into a pro-inflammatory state than an anti-inflammatory state. And so that was actually also evidenced in this study. So one of the things that we're seeing then essentially is that iron is actually, this sort of iron from hemorrhagic infarct is cardiotoxic. So the key observations from the preclinical studies are that the MI is hemorrhagic. So there's hemorrhagic versus non-hemorrhagic infarcts. There's a target, right? There's a ferric ion that is a target. And it has to be low molecular weight, and it has to be able to get in, and it has to be able to, whatever it is that we're going to use to remove it has to be the one that is low molecular weight. And then it should be able to remove the ion both from the intracellular and extracellular space. The reason I'm saying this is because of those who know about the TAC trial that did EDTA as a chelation, and that's published in JAMA, which was like kind of half okay, half, depends on how you look at it. It's not really a success story. And that's because their chelator is EDTA, and it's just essentially an extracellular chelator, and it doesn't necessarily chelate for Fe3 plus iron. So they were on the right track, maybe not using the right chelator, and not really specific to iron either. But so this would have an implication for ongoing studies in the clinical space that I was talking about. So that sort of a chelator that we would need, that would allow us to do this sort of translational studies, particularly in dogs first, would have to be something like a deferriprone, which actually has those characteristics. So we did that study, and that's also part of that Nature Communications paper, where we were able to look at this with MRI, and these treatments were able to demonstrate that we are able to remove iron inside the infarct zone in a hemorrhagic infarct. But not only that, but we are also able to reduce the amount of fat inside the infarct zones, which otherwise would have been a lot larger. So clearly we are able to modulate the physiology a little bit because we're removing iron, and we expected it to, but still has to be shown, and that's being shown here, But then the fat part is the physiological part where there's that relationship on being able to mitigate the effects of fat in foam cell formation. And we were able to demonstrate that here. Okay, so that's a study that went on for some time. You can imagine doing these studies, right? They're very, very tough. You're studying these animals for a long period of time. The chelator was administered only for 8 weeks. And it's a super expensive study to do this and to get this in the right amount of sample size and everything to be able to demonstrate this. So that was is a really a very challenging study, and the team worked super hard on this, and we were able to get to this point. What we also saw was the functional difference was also very, remarkable from at least from the, one dose study that we did, right, in a large animal model, granted, we were able to see far improved functional recovery in animals that got the deferriprone versus that didn't get deferriprone, but were matched to have hemorrhagic infarct in the beginning. But we also matched to infarct size. And that allows so much filtering of all these animals, so for us to be able to isolate this effect. So clearly, we're demonstrating a continuum, a pathway in sort of hemorrhagic infarctions evolving into fat. And if you can actually remove the iron and reduce the fat, then we will actually have a better outcome. And that makes a little bit of sense to me, at least intuitively. If you have fat and the way the heart contracts, right? If you have fibrotic tissue, it's actually not bad because the heart can actually contract against it. If you have fat and you push, it goes this way. So, you don't really get that LVEF that you would like. So reducing the amount of infiltrative fat or replacement fat in this case would be actually, seems to be beneficial. Okay, so this set up the first in-human trial around treating hemorrhagic infarctions. So this is what we call Myron DFP, and it's a randomized placebo-controlled trial to mitigate the long-term effects. It is recruiting, and we have about 6 different sites that are participating, and we'd love to see others that want to participate, potentially out of here, would be outstanding. I think this is something that is exciting to us, but I would imagine that this would also be exciting to others that are really looking at the first treatment. Okay, so I'm going to stop there for the chronic infarcts, and I'm going to start talking about acute damage that reperfusion hemorrhage causes. So the question is, does hemorrhage drive final MI cells? Okay, we know large infarcts have hemorrhage, but the question is, does hemorrhage actually have a role in expanding the infarct cells? So, like I said, is this just sort of something that happens, or is this something that we can actually visualize? And this is where imaging has been instrumental, particularly PET-MR for this study. Okay, so as I mentioned to you a little bit earlier, the hemoglobin breakdown into heme presents a toxic target, a toxic substrate inside the myocardium that can actually now start to interfere with the salvaged myocardium post-revascularization. So does this actually play a role? So based on this, we would imagine so. So this is just some mechanistic pathways that we're still exploring a lot more of this. But we said, okay, this is all happening. Then clinically, we should be able to see a post-troponin rise that is differential in hemorrhagic infarcts versus non-hemorrhagic infarcts. And that's actually, we saw, that's something that we did see. So this is a study in about 64 patients looking at post-BCI troponin kinetics. And what we found is that the troponin rose earlier and higher in hemorrhagic infarcts compared to non-hemorrhagic infarcts. And there's some other parameters in here. And what we also saw was, obviously, there was a hemorrhage volume that was indicative. That was pointing to a larger infarct size as well. Okay. That's not going to be enough, right? So what we wanted to do was we wanted to do a study inside the magnet. We wanted to cause ischemia. We wanted to reperfuse. We wanted to know the area at risk. We wanted to know the time resolved changes with LGE over a period of time to be able to see, is this true? So what we had to do was essentially create an animal model where the area at risks would be the same. and then look at what happens, right? And we're essentially doing time-resolved imaging in some ways. And this is why I love PET-MR for this particular purpose, because this is the one that allowed us to do what we did. And what we saw was that, what we saw was the following. So this is hemorrhagic infarcts, non-hemorrhagic infarcts, and you can see that the area at risk is not that different, but the evolution in terms of infarct size indicated by LGE in the middle there, you can see it actually evolving. And you can see a lot of microvascular obstruction and hemorrhage that we see on day 3. So the MR images are showing hemorrhage at 3 days, but the LGEs are actually happening at, less than 1 hour after reperfusion, 24 hours, 72 hours, day 5, 7, and week 8. And look what happens. When we look at the infarct size, this is all normalized area at risk, and you see the hemorrhagic infarct. Look how it is. It's at 1 hour, you essentially have very similar infarct size on both groups. But then once you go in time, this starts to go up significantly. Actually, within the first 24 hours, there's a very large increase in infarct size in the hemorrhagic group than in the non-hemorrhagic group. So even in non-hemorrhagic groups, you're seeing this effect of reperfusion injury, if you will, because the infarct size is going up, but it's not going up as much as in the hemorrhagic group. And if you look at the myocardial salvage, which is basically the infarct size, area at risk minus the infarct size normalized by the area at risk, then you don't really have a lot of salvage myocardium left in hemorrhagic group after revascularization compared to non-hemorrhagic group, which is actually the case, what I presented earlier, which is this. In reperfused MIs, in the absence of hemorrhage, we see one size of infarct, and then the other one, we see a very drastic change in infarct size. And so the benefits of reperfusion therapy in hemorrhagic infarcts are particularly heavily diminished. So we said, okay, well, we don't know what MR is really saying, okay? That's really going to lead to a clear answer. Is it going to lead to an infarct size, the scar size? Is it going to be different between hemorrhagic infarcts and non-hemorrhagic infarct in the chronic phase without all this stuff that's going on with LGE, particularly in the acute phase? Remember, the area at risk is the same. So there's no difference in area at risk, but look at the way the infarct sizes turn out. In hemorrhagic infarcts, the infarct sizes are at least twice the size as the non-hemorrhagic infarcts. So even though the starting point is the same, once the hemorrhage actually evolves into the infarct zone, we have a totally different story. So all of this then set us up to write this consensus statement, essentially published as the CCS classification for acute myocardial infarction at the end of last year, which goes like this. So we are saying that not all reperfused infarcts are the same. The injuries that reperfused infarcts sustain are different and depends on the type of involvement that is present after reperfusion. So stage 1, aborted semis, essentially knowing the infarct size is essentially negligible. You might see a little bit of edema, but it's gone once the stent is put in. Second phase is you have cardiomyocyte necrosis, but there's no microvascular injury. The third stage is you have microvascular injury and you have cardiomyocyte necrosis, but the hallmark injury of stage 3 is microvascular injury. Microvascular obstruction, I would call it, because I've also already defined another form of microvascular injury, which is the worst case, which is microvascular intramyocardial hemorrhage. So stage 4 is a case where you have significant cardiomyocyte necrosis as well as microvascular obstruction. On top of that, you get intramyocardial hemorrhage, and that is the stage 4. So you might say, okay, well, this is all fine, but is it prognostic? Does it drive outcomes? And that's something that I will show you in a bit. So this is a progressive injury, right? So you start at some point, and as you go through this injury that is taking place with reperfusion, it is additive, right? So in the first, you have normal myocytes, essentially not that different in CCS stage 1. You have a little bit of edema, but that's pretty much gone. And then in stage 2, you have cardiomyocyte necrosis, you have interstitial edema, you have a little bit of the viability. Well, the viability is lost, and this is an irreversible injury. The stage 1, you have a reversible injury, it'll come back, and then there's no microvascular involvement. And then in stage 3, you're going to have cardiomyocyte necrosis, edema, microvascular injury that commensurates with microvascular obstruction only. And then in CCA stage 4, all of those things that I've described in stage 3, plus you have intramyocardial hemorrhage. So this is how we classified it. Now, if you look at the literature and you look at MACE in these patients, there is incremental prognostic effect. So if you look at cases where you have aborted STEMIs, and then you look at other cases, stage 2 to stage 4, there is an increase in MACE. But if you start to, look at this a little bit more closely and in a refined fashion, you would go to the top line, or the top panel, which shows that compared to non-hemorrhagic MIs, that includes microvascular obstruction, to the case where you have hemorrhagic infarction, your MACE risk is actually 2-fold higher. So this is patient data, right? This is collective patient data that we're reporting. And another thing that you'll notice is that hemorrhage is not happening just in a few patients. It's happening in between 25 to 40% of the revascularized STEMIs. So some patients who get revascularized with a great TIMI score and then don't do so well, I think it has basis over here. But this is data coming out of MRI only, right? Because we have to identify patients who have hemorrhagic infarction, and that's basically 3 to 5 days post-PCI. And so when we actually look at this is European data and the US data. If you look at data in India or China, this number is actually, if I tell you, you won't even believe it. It is 70 to 80% of the patients are actually hemorrhagic. So it's a pretty serious problem in other parts of the world. Okay, so the next and the last thing that I want to kind of talk about is reperfusion injury. As an imaging person, it's a little bit painful, but I'll describe it anyways, because MRI is really the gold standard for diagnosing hemorrhagic infarcts, but the problem is that it can only be done 3 to 5 days after. Patients are unstable, not cooperative, arrhythmias, all sorts of issues. And then you revascularize the patient. You want to find out whether the person is hemorrhagic or not by putting them into an MR scanner within 2 hours of PCI. It's not going to happen, right? So the question is, can we actually come up with a blood marker to identify hemorrhagic infarction? So, hemorrhagic infarction essentially started out with identification in animal studies was histology, right? And then cardiac MRI is a beautiful technique, but we have limitations, practical limitations in trying to do this in the clinical arena. So this is a study that is still recruiting, or I think this one is closed, but post-PCI troponin kinetics for diagnosing hemorrhagic MI. So I mentioned to you earlier in 2022, we published this paper in JACC, which showed this differential troponin rise between hemorrhagic and non-hemorrhagic subjects. So we asked the question, can this become a diagnostic tool, right? Can we actually look at that? But prior to that, we did all sorts of stuff. We did proteomics, we found, discovery proteomics, we found certain proteins, but then we were presented with, now we have developed targeted assays on proteomics, and that's going to be insanely expensive. Nobody's going to use it. So we wanted to see, while that whole other idea was evolving in terms of hemorrhage maybe causing infarct size to expand, we said, okay, well, troponin looks good, but is it diagnostic? So that's what this trial is. So this is myron trope, and you can see all these are kind of starting with myron. They all have that as a prefix. And so this study, which started a couple of years ago, essentially just finished. And this is now going to be presented at a late-breaking clinical trial in CRT in DC. And the data is truly exciting. It's something that is a little bit unbelievable, but now I can actually look at the troponin curves, and I can post-PCI troponin curves and tell you who's actually hemorrhagic and not, even before an MRI is done, because we have particular cutoffs. So for this study, what we did is we did an hourly blood sample, and we measured the troponin in post-PCI patients STEMI patients, and we were looking at it every hour to 12 hours, and then 16 hours, 20 hours, 24 hours, and 48 hours. And then we would do an MRI on the third day, and that was our discovery cohort. So we looked at these troponin values and how they actually evolved. There was actually an animal study involved in this too. But in the patient studies, it was 150 patients that were studied like that. And then we identified thresholds from ROC analysis, and then we used those thresholds to validate by looking at another 50 plus patients where we applied these cutoffs and then asked, okay, these patients are actually hemorrhagic based on these troponin values. What happens when we actually do a cardiac MRI scan? And we tested that, and we had pretty remarkable concordance on that analysis, suggesting that this is actually a very good marker. And you know that the reality is that the separation is not 1 nanogram per milliliter. it's like 50, 60, 70 nanograms per milliliter. So there's not even a question whether this is actually the separation. We're not talking about a 20% separation. We're talking multifold separation. Okay, so this is the type of curves that we would get, right? So if you look at the time kinetics are very, very different. Rapid rise and then a slow fall. And then the other cases, they would rise in the non-hemorrhagic infarcts and then they would fall, but they have a very different time course of activity. Okay, so this is basically collective data across patients that we're looking at, and this is basically around 150 patients. And you can see the red curve is hemorrhagic patients and the blue curve is non-hemorrhagic patients. And this is sort of the area under the curve. So we can actually look at, we can look at post-PCI troponin. We don't necessarily have to collect it in the first hour. We can collect it within the first, 24 hours, and we can go back and say who's hemorrhagic and who's not, right? This now sets us up very well to do clinical trials because we now know who we should actually recruit into this study and also who we shouldn't actually put through the MR scanner for no particular reason because they're not hemorrhagic or it would help us with at least screening even in the deferiprone study. So anyways, I want to try and close this thing so have a chance to answer some of the questions. So I think this question, does it matter? I think it matters. I think you've seen quite a bit of evidence on this, and this has been years of work. First is I just want to highlight that hemorrhagic infarction does have a role in the interpretation, at least on the post-PCI troponin, because we've seen these post-PCI troponin patients not do so well when they're actually at high elevation. And that's knowledge that is pervasive, and it started around 2011, 2012. Everybody was measuring post-PCI troponin and saying what it is. But now the difference is we know that it's very much likely it's hemorrhagic infarction. And so now we have a target. So maybe we should find ways to reduce hemorrhage, reduce ways to reduce the toxicity of hemorrhage and that sort of thing. So the second thing is that there is an acute damage that happens with hemorrhagic infarction. I mentioned to you that you can actually have a huge loss of myocardium, salvage myocardium, if hemorrhage were to be present. So can we actually block activities that would actually reduce the infarct size from getting bigger? And the chronic issue is that it's a prolonged inflammation. We've heard about that. That's a bad thing in the heart post-PCI. If it lasts for long, it's really not very good. And the substrate remodeling. I did not touch another topic, which is EP. And we've done some work on that as well, and others have done it as well, where people have shown whether you have iron, you have fat, you're at a higher risk for fatal ventricular arrhythmias. So I'll just close by saying that this is not done yet, but therapies targeting iron homeostasis from reperfusion injury potentially holds the remedies for post-PCI events. With that, I want to thank so many people that have helped put this paper together, this entire work over these years, and that comes from many different organizations, and most importantly from my team that have really done the bulk of this work. And then with that, I'll just close this by saying, we are recruiting patients on this for this Myron trial, and we have a very sophisticated system that is in place. So this is not an advertisement, but this is anybody who wants to participate. We do have multiple clinical trials that start with the prefix of Myron. and we are actively recruiting across sites. So it allows people to input information and things like that much easier than having to wonder, okay, what am I actually putting in? Who, you know, so there is a very streamlined process that is in place. And this is just going to play for a minute or so, and then, but in the meantime, I'm happy to answer questions. Thank you so much.
I'll ask the first question, then maybe pass this. So that was really wonderful. I was hoping you would talk about this topic as we discussed earlier, because there's a lot to learn and it's an evolving story. In your experience, has there been any associations between intramyocardial hemorrhage and the likelihood of, in the acute phase, rupture?
Yes.
And or in the chronic phase, aneurysmal formation?
Yeah, both are true. So rupture is actually one of the key things that is very difficult to predict. And I think when you have hemorrhagic infarction, you get these dissections that actually can rupture. And there's evidence. We have evidence on those things. That's coming out. I think others have published a little bit on this. And the Canadian Cardiovascular Society guideline, or that's not guideline, it's an expert consensus statement, actually does identify myocardial rupture as a critical problem. And aneurysmal formation, we have also seen that. So I think yes to both. Yeah.
Very exciting talk. So I'm wondering, the iron released from macrophage enhance the fat formation. So what kind of cells produce fat in this myocardial infarction? And the second quick question is, so what drives the myocardial infarction in some patients with this microvessel like a hemorrhage, but some patients just with regular myocardial infarction? What drives the difference for this myocardial infarction?
So we have now identified factors that drive hemorrhage in some patients than others. The simple answer is that the longer you wait to revascularize, the higher the chance you're going to get it. But if you have vascular problems that affect the vascular integrity, diabetes, hypertension, these sorts of things, smoking, then your vasculature is already permeable to some extent. Then on top of that, you put a hydrostatic pressure that just bangs at it, ruptures the vessels. But there's other factors that play. So we have been starting to develop algorithms, particularly AI algorithms, that are centered around factors that would drive hemorrhagic infarction even right before revascularization. That helps you? So, and that answers the next question I think you asked, is that what's going on with these macrophages? The macrophages are actually engulfing phospholipids that are dead, that are in front of the myocardium, and they go through a lipid peroxidation phase in presence. And together, they actually enter the cardiac macrophages, and that they seem to actually accumulate that. So there's a pathophysiological process that happens only in the presence of iron, and transforming these macrophages that are already in a pro-inflammatory state into. Thank you, doctors.
Thanks, Ryan. Nice talk. So I'm curious about a couple of things. One is, has anybody looked at, I'll call it the biomechanical signature of the hemorrhaging and the iron deposits and lipids and all that?
That's Eric's question, essentially. So
okay.
That is, people haven't looked at it.
Sorry, I didn't interpret it.
It's very connected. It's not direct, but I mean, that would tell you something about whether it's prone to rupture or not. So that's something that we're looking at. And obviously it's coming out of the MRI.
Yeah. Well, or maybe even ultrasound.
Yeah, there's other ways. I mean, now, you know, if troponin opens up like this, then you can do echo and also.
Yeah, if you could get a full 3D map.
Exactly.
And then along or related, what about, can you see any of the hemorrhaging with CT or CT contrast?
Yeah, so I think people have tried to do it. At least one group from South Korea tried to do it. Sensitivity is just not there. I don't know, there may be, I don't know, Alan, you might comment, but I haven't seen literature on hemorrhagic infarction, but it's not because it's just not being tried. But you would imagine that there would be something there, right, with the metal being there, but I don't.
All right,
Well,
very.
The vendor asks this question.
Sure.
Dr. Khan on the line asked a very interesting question I saw.
Sure.
Sam, are you able to ask your question? Unmute yourself and ask it, or maybe Rohan can ask it. It's related, so.
Sure.
Yeah, exactly. So it says amazing summary. Have you looked at unloading LV and its effect on hemorrhage?
Oh yeah. Yeah. I mean, I know there's all this work going on with Impala pump. So that's one way of doing it. I think some of the activities that they're seeing with Impala, I think does go back to this LV unloading and things like that, that would prevent or mitigate the development of hemorrhage. But there's other ways of doing it. So I think that if you do the MR, I think you will find that to be the case. I don't have evidence though. Yeah. Yes.
Wonderful, wonderful work. So this is a little bit of a, I suppose, a chicken and egg question. You described how in those stages that you listed that severe microvascular injury and myocardial or intramyocardial hemorrhage go together. And there were data, old animal data, that if you block leukocyte recruitment and adhesion, that you prevent reperfusion injury, which I know is not equivalent to intramyocardial hemorrhage. But so I'm just thinking, I mean, it still seems like, again, the inflammatory process is major, and that rather than chelating the free heme, that you would still like to be upstream of that,
Absolutely.
right? And
Yeah.
prevent
Yes.
the chemokine release and the leukocyte recruitment and the injury of the endothelium and of the small vessels in order to promote the hemorrhage.
Yes.
Would you agree with that? I mean,
I agree with you. So there's a lot to be done, right? So the thing is, these are snapshots in time. And let's say chronic infarct, right? You have a patient who's chronic infarct. What do? Can we actually stop that process? Ultimately, I agree with that. I think you got to go upstream. Can we actually even stop hemorrhage from starting in the first place? That would be it. Then all of this stuff is done. But then we're not there yet. And I think it's going to take a long time to get there because interventionalists don't necessarily want to change practice too much in hospital systems and everything like that. So we'll go with that theory for now anyways. But I do agree with you fundamentally. If you can stop hemorrhage, then what are we talking about? We probably have minimal damage. But there's different places to intervene, right? There's multiple places to intervene. And it really also depends on the patient history. Are we doing this in hospital? Are we doing it after discharge? Are we doing it 2 months after discharge? There's a lot of questions that are still open. Yeah.
I have a kind of question. So comment. So I mean, I've done a lot of controlled reperfused infarcts, and sometimes we see hemorrhage and sometimes we don't, and have never kind of figured out why we do or don't. And I guess one of the questions is what is the role of preconditioning? And what is the role of anticoagulation in these interventions?
So great question, by the way. So this is something that we wondered too, right? So we would do, this is how it goes. So in dog models, anyways, that's kind of what, I can talk about pig models too, but dog models, if you do 30 minutes of ischemia reperfusion, you hardly get anything. If you do it for 90 minutes, you'll get a little bit of infarct, you'll not get one. You might get 1 out of 10 times, you might get. You go to 3 hours, you're going to get hemorrhage 2/3 of the time, not all. And I think it has to do with the fact that there are variations in level. So that's one. So I think that also explains some of the preconditioning stuff may also play a role in that area. If you precondition the animal with ischemia, they're better able to, recruit vessels and, kind of ready to go with type of thing. So in that arena, I can give you some answers on the clinical side too. So we've been looking at coronary collaterals. We've studied this now in about 600 patients. And what we're looking at is that if you have grade 1 collateral, essentially, chances of you developing hemorrhagic infarction is higher than somebody has grade 3 collateral. So collateral seems to be when it comes to antiplatelet and anticoagulation business, that is something that I'm very scared to touch because you know, how the clinical practice is. There's a huge value in doing all of that thing. So we have to, you know, we had a meeting in Indiana last year where we had a chronic lineal, and we had, you know, Sunil Rouse and Roxanne Mera, you know, all these people that are, you know, experts in antiplatelet therapy. And that is actually a problem, right? If you think about it, because if you're doing this, you might be actually making it worse. But at the same time, you don't want to have stem thrombosis, so you have to kind of, how do you titrate this thing down? So that's going to be very interesting and important. And secrets are we can radiology grant around that because we have some data. I think we'll see how that evolves.
Well, I mean, a bit of a follow-up, but I've always, you know, wondered, you know, obviously PPA and,
Yeah.
you know, I mean, you know, we know that if you treat too late, you actually cause potentially more harm.
Yeah.
And I wonder maybe if anyone's explored whether this hypothesis, this driver, is the reason for that observation.
Yeah, I think you're right, because so there's, you know, if you do really late, 24 hours, you know, somewhere in the woods, you know, you can get patients get done, whatever, and you're reproducing 24 hours after or 48 hours after, are they at high risk of all of this? Yeah, I think so. But those are I mean, those are decisions that are made clinically. But what I'm talking about is even well past the golden hour, you get into 3 hours of whatever ischemia, and you come in and the person has no collaterals. What are you going to do? You're going to reproduce them. They're going to be okay. They're going to have infarct, but that infarct is expanding. So that's the case where it's even more important to do something to help these patients.
Okay. So very nice presentation. So many of the data you presented outcome data were based by other function. So
yeah, so
based is it just
so the major ones that I'm talking about are death, right? When it comes to MACE, yeah, usually you include stroke in the MACE. I'm not talking about that. They're talking about MACE. They're talking about we haven't got I didn't the data on mortality, but mortality, right? Readmission, these are the things that
Yeah, Professor, thank you so much for the great talk. One quick question. I was really interested in how you talked about there's a lot of variance in hemorrhagic stroke or in hemorrhagic depending on geography. And then you also talked about the biomarkers in the clinical trial. And I was wondering if you've looked at any other predictors of who has a hemorrhagic MI based off epidemiological factors, prior clinical history, family history, whatever else that might be easier to use in a clinical setting than getting a formal biomarker.
You mean who predicted biomarkers?
Yeah, predictive of who gets it based on epidemiological factors, maybe.
Yeah. So I mean that's what we're working on. That's the algorithm that we're working on. Is now looking at about 1,000 patients who we have information on who's not. But the ones that are emerging are very clear. Smokers, that seems to be very clear. You know, left main. Imagine that contributes to the ischemia time part. And then, sorry, but males are worse. That seems to be also the case. There's a difference in versus female. So those are some of the major things that we remember. Underlying extent of diabetes and hypertension, these are all going to matter as well. You know, so some of the underlying clinical comorbidities you might be at higher. Then if you don't have great collaterals, so we don't really like. It's a very multifaceted problem in terms of predicting who's going to be hemorrhagic.
Yeah, thank you so much.
Yeah.
So with that, I really would like to thank Rohan. That was more of a one talk.
Yeah. Thank you so much. It's been real great conversation. Yeah. Thank you.
So this is the off-field, maybe not space.